from Singapore, Dr. Matthew Wong. This is only my second time in this university since I took over the job of Southeast Asia Regional Head in 2022. And the first time we had a meeting at the boardroom and we had plans to engage in more educational activities. And the first of which was our sponsorship in the IDCMR October last year. So I believe I asked Lynn that for the past 3 or 5 years, GC has not been doing such event in this university. And my pledge to everyone is that when you need us, we will be here. So in November, I'm now pledging that we will bring in a speaker. I believe that you want Professor Yingo, so it is confirmed. GC will be more than happy to bring him for you for this particular event. So why have we decided to bring Matthew today? You know GC because of Fuji. I don't think there's any dentist in Vietnam that doesn't know Fuji. Fuji is such a very strong name in the dental market in Vietnam. However, GC is beyond glass ionomers. And because our vision of being the leading dental company, empowering health professionals to have a healthy and long-living society, we would like to offer solutions to your practice. And today, Dr. Matthew will give you some of these solutions which you can immediately apply. I believe nowadays I see a lot of very young dental professionals here. Most of you are using composite, if not 90 or 95% of you are using composite. So today we would like to offer you something unique. This type of composite that we have is something which is not comparable to the other composites available in this market. In fact, we are only one of 2 companies who have composite in the injectable form. So I don't want to talk more about the advantages of this one, but what I would want you to do is try to benefit and please ask a lot of questions from our speaker today. We'll be more than happy to answer your questions. And this education does not end here. I believe you can get in touch with him, or not you already committee. Get in touch with him through email or WhatsApp or Instagram so that you can ask more and talk about your challenging cases. So with that, again, thank you to the Hanoi Dental University, Professor Song and his board. And I also would like to thank our GC Vietnam team led by its country manager, Mr. Lin, and regional sales manager, Ms. Jane. And I see our new partner there at the back, Dr. Hak of TP Dent, who just walked in just in time. He's our newest partner here in Hanoi. So thank you for all your support to GC. Good luck and all the best. Thank you.
Xin gửi lời cảm ơn tới những chia sẻ của ông ạ. Và tiếp theo chương trình của chúng ta sẽ bắt đầu chương trình hội thảo ngay bây giờ ạ. Xin chúc chương trình hội thảo chúng ta thành công rực rỡ. Và hội thảo có các CME 8 tiết tương đương với 4 giờ tín chỉ. Nếu như anh chị nào trong hội trường chúng ta có nộp hồ sơ bao gồm bản giao công chứng và tốt nghiệp hoặc chứng chỉ hành nghề thì chúng ta có thể nộp bản tiếp đón ạ. Buổi trưa hôm nay do thời gian có rất là ít cho nên là ban tổ chức cũng tiết kiệm thời gian, chỉ có 30 phút giải lao buổi trưa và công ty GC đã tài trợ mỗi hội thảo viên một suất ăn trưa. Và mỗi giờ một suất ăn trưa tại chỗ luôn ạ. Thì cái năm anh chị sẽ ở lại hội trường là chúng ta sẽ dùng buổi trưa tại chỗ. Và nếu như ai không có nhu cầu thì xin vui lòng báo lại cho ban tổ chức để chúng tôi sẽ trừ suất ạ. Và xin cảm ơn quý vị và tiếp theo đây chúng ta sẽ đến công đoạn test mic. Xin mời anh chị xem test tai nghe. Nếu như ai có nhu cầu cần hỗ trợ thì chúng ta giơ tay lên để ban tổ chức có thể hỗ trợ tại chỗ ạ. Mọi người vẫn nghe tốt chưa ạ? tiến một thầy chưa ạ? Ok.
Good morning. Thank you very much. I have to admit, it's very rare I get to start on time. It's perfect 8:30, so thank you very much. I want to thank Hanoi Dental University for inviting me for today. I want to thank GC for the opportunity as well. Hopefully after today, everyone will be able to go home with some kind of knowledge update that you can apply into your dental practice tomorrow. Okay? Today is going to be a long day. Today we'll be focusing both on anteriors and posteriors. The plan today is that we're going to start talking about posteriors first. I'll spend around an hour and a half to 2 hours to talk about, on the lecture side of things, why we do certain things, how we do certain things, and then we'll give everyone a bit of a break, because we need a break. And then what I'll be doing is I'll be doing a live demo on applying what we have learned, or what I have shared with you guys today. Then we'll break for lunch. After lunch, we'll come back. Then we'll start anterior. Anterior is a little bit different, because anterior there's an aesthetic component to it. So we'll be doing a bit of lecturing, then a demo, then lecturing and demo, and hopefully we'll wrap everything up by around 3 o'clock. Is that right? That's good? Good. To start, can I ask, how many of you are already using the GC composites? Hands up. Okay. How many of you are using 3M composites? Hands up. Okay. What other brands are you guys using? Can you shout it out? Tokuyama. What else? How many of you are using Dentsply ceramics? Dentsply ceramics, none? Wow, okay. Okay, so Shofu? Yes? Ivoclar? Yes? Okay, fine, good. So, I'm going to start by saying this, right? A lot of the techniques and the philosophies and the ideas I'm sharing today, it doesn't matter what material or what brand you're using, it's still applicable, all right? I'm not a GC salesperson. I'm not here to tell you that GC has the best composites. What I am here to tell you is what I look at when I'm choosing a material and why it works in my hands. And hopefully this is something that, can inspire you guys as well. Let's start first. A little bit about myself. My name is Matthew. I did my training in the UK back in 2009. And then I moved to Singapore in 2014, set up my business in 2018, and been working in private practice ever since then. Everything I'm sharing with you today is not new. I didn't invent any of them. I'm only fortunate to be able to be in this room sharing everything I've learned so far because I had the opportunity to meet mentors, my teachers, the people who has inspired me throughout my entire career so far. Some of them that you have heard of, some of them you may not have heard of, some of them they're not even dentists, they're dental technicians. You have no idea how much I have learned in terms of anatomy, occlusion from the dental technicians that I've worked with over the years. So I owe them a lot.
Alright? So for the younger generations out here, my advice to you guys is find a mentor, find teachers, find people who inspire you, and continue to learn and work with them. Recently, I've been a graduate of the Koi Center in Seattle. It's basically a training center by Dr. John Kois, where they teach more advanced dentistry, advanced treatment planning, occlusion management. Really helped me quite a lot as well. Okay, what are we going to do today? Today, when it comes to the posterior course, we're going to talk about a few things. We're going to talk about failures first, because that's the best way to learn. You learn from your failures. So we're going to understand the failures, what failures that we're seeing, why are we getting failures, and how we're going to manage them. Then we go back step by step, right? We're going to learn how to start with cavity preparation, not cavity preparation, how to make the hole, is how to prepare the surface of the cavity to receive the filling material that we're going to place in, right? Then we're going to rethink on how to choose your matrix system, your sectional matrix, your Toffel-Meyer. We're going to talk about how to choose that, what are the main things that influences the success or the failure. We're going to talk about material selection, how I choose my materials, what are the properties of the composite materials that I look at, right? And finally, we're going to talk about flow holes. As what Victor mentioned a while ago, right now I use two types of flow hole. One flow hole that's very runny, one flow hole that's very stiff, which is fantastic for two separate indications, but both are very useful in my clinic. Then finally, we talk about function, because a lot of times when people do courses on posterior composites, what do they want to learn? They want to learn how to do this. They want to learn because they see on Instagram, they see on Facebook, people posting cases. They want to make the posterior restoration look very nice. They want to learn how to build up. They want to build up to make something that looks aesthetic. Who here has attended these kind of like workshops or courses that teach you how to make really nice composite restorations? Hands up. A few of you, right? Good. Now, in the very beginning of my career, I used to attend a lot of these courses. I would attend a weekend course. I would learn from someone who would say, oh, you have to do the cusp, one cusp, look very nice. You spend 2-3 hours on one filling, and you feel, oh, wow. You take photos, put it on Instagram, people will like it a lot. Then what happens? The next day, I go to work. First patient comes in, it's a large class 2 restoration. I look at my nurse and say, ooh, take out the camera. So I start doing it. I spend my time, take my time, make it look really nice. I take photographs. I sit the patient up. Sir, bite down. What does the patient say? What does the patient say? It's too high, right? What do? It's okay, sir, that's fine. Doctor, still high. What do you do next? Again for 15 minutes until your nurse is fed up, you're fed up. So what do? Good. And then you delete the photos. Right? So that's the thing, right? We tend to try our best to make things look aesthetic, but it doesn't fit inside the patient's mouth. But at least you get rid of it, fine, patient leave. The next day, patient calls you. What does the patient say? Doctor, sensitive. Yeah? And like, never mind. 1 week. You wait 1 week. 1 week later. Doctor, still sensitive. Wait 1 month. 3 months later. Doctor, the filling drop out. It happens, right? These are things that happen. So you would spend so much time adjusting, and this is what you end up looking like, right? You aim for something that looks really nice, in the end everything is flat. Then the patient comes back, tells you that it hurts, it's sensitive, it drops out, you lose function. That is to me what failure is all about. Can I ask, in Vietnam, is this what often happens as well? It's not just me, right? Oh good, more people are nodding their heads, that's good. Now, when we talk about failures, it's not just what I mentioned a while ago, other things like, poor aesthetic, it doesn't last very long. Food trapping, food always gets trapped, it takes too long to make, the color doesn't match, the contact is not good, the filling got out, so on and so forth. Now, when I started as a young dentist, and I see this, what do I say? Composite not good. I use amalgam will last long time. I use GIC will last long time, composite is not good. That's what I say, I blame the material. Right? I blame companies like GC. Your composite is not good. What does the research say? In 2014, Opdam came up with this literature study that looks at failures and analyzes what sort of failure you get every year. And one of the things that we notice is that during the first year, the most common type of failure is endo. Meaning to say, a lot of times, a lot of dentists, they treat teeth that shouldn't be treated with a filling. They start treating teeth with a nervous dead already. So they've done a lot of misdiagnosis. So that's the number one failure. Then you look at year 2, year 3, year 4, year 5. The thing that is getting more and more common is secondary caries. Yeah? What does that mean? It means that year after year, because the bonding is not done properly, they're starting to have micro leakage, bacteria is going underneath, and therefore you start getting failures over the years. So what am I trying to say over here is that there's actually very little evidence to show that the failures that you get is relevant to the material that you're using. What are they trying to say? They're trying to say, whenever there's these sort of failures, whose fault is it? Me. Not the material. It's me, it's you, it's us. Alright? So my job today is really to go through each and every step to understand where this failure is coming from, and hopefully tomorrow, when you go back to work, you start changing some of the things that you're doing. Okay? So we do it step by step first. We start by isolation. We learn how to make sure that the area is nice and clean, nice and dry. Then we talk about the cavity preparation, not just about drilling the hole, but how to prepare the surface to receive the filling material. We'll mention about etch and bond. A lot of people think etch and bond is basically like, its job is to be the glue. It's not a glue, it's more than that. Then we do the dentin seal, how to seal up to make sure you minimize the chance of secondary caries over time. We will talk about material selection because unfortunately there are many different brands of composites out there. Different materials work very differently. It works very differently on everyone's hands. Yeah? We talk about the buildup of the proximal wall because that surprisingly influences how much time you spend adjusting. That also influences the amount of food trapping that the patients will face. We're going to talk about core buildup. Yeah? How to fill up that hole. Because that is something that normally takes a lot of time. I want to speed things up a little bit. And finally, only then we talk about the thing that most people are here to learn, how to make the surface look nice. Does that make sense? By the way, how am I doing so far? Speed is okay? Good, thank you very much. If I am speaking too fast, and if there's anything that you want to ask, I'm okay, just please raise your hand. Understand? Good? Alright. Let's talk about isolation. Hands up, how many people over here is comfortable using a rubber dam? One, two, three, four, five. Don't be shy, it's okay. Are you an endodontist? No, right? You are. Of course. Now, things that people think rubber dam is for, the main reason is basically for moisture control. That's correct. Moisture, unfortunately, is the biggest enemy for any form of restoration, even amalgam. Okay? But it's just with the composite, it's a lot more sensitive to moisture. The problem with working without rubber dam, to me, is less about moisture control, more about the field control. What do I mean by that? Without rubber dam, I have to use one hand to retract the cheek, I have to use another hand to retract the tongue, my assistant has to use one hand to suction the saliva, and I have to somehow find another hand to actually do the dentistry. So there's very much distraction around the area. I don't get to focus on the area that I'm working on. And this is provided that the patient is well behaved. If you get a patient that moves around, the tongue is moving around, the tongue is very misbehaving, this is a thing that's never going to work well, right? But what else? One of the main reasons for me to use rubber dam is exposure. Because when the rubber dam is placed properly, what it does, it also compresses the papilla. When it compresses the papilla, it allows you to see parts of the tooth that normally without a rubber dam you will not be able to see. It exposes decay, caries, issues, general issues that normally you would ignore because you can't see it. But with a rubber dam, everything is clean, everything is predictable, right? What else? Like this case over here. Without a rubber dam, I won't be able to see the decay, let alone clear the decay. But with a rubber dam, it just makes it a lot easier. I get to focus more. Look, understand, placement of rubber dam to some of you guys is difficult. It takes some time to get used to. There is a learning curve if you've never done it before. I say this, but you have to also remember when you started as a dentist, when you learn how to do your injections, your IV blocks, there was also a learning curve, but eventually became second nature. Right now for me, placement of a rubber dam takes 1 to 2 minutes. But in terms of success, it drastically increases my success rate. So my advice to a lot of you, especially the younger dentists who's more open to these new methods, new techniques, and new workflows, learn how to use rubber dam. Find someone in your community that's really good at rubber dam, and learn from them and get used to it. Yeah. Actually, there's one more thing. This paper just came out in 2022-2023 by Marcus Blatt's team. So one of the things that he found was that even with the best isolation technique that you can find, the bond strength when you work without rubber dam is cut by half, regardless of what material you use. Now this is important because what it means is that the moisture, the moist air inside the mouth is enough to affect the bond strength of the material that you're using, right? It's cut by half. So absolute isolation would be necessary to increase the bond strength between the enamel and also the dentine, regardless of what system that you're using. Does that make sense? So depending on timing, I can do a live demo of rubber dam as well, but we'll see how we do with time. Okay? Okay. So far so good? Let's go. Next we're going to talk about cavity preparation. This is Tammy. Tammy came in with a large amalgam restoration that's dropped off. This is what it looks like underneath. And this is what it looks like after I remove decay. Here's my question. How many of you would put a liner or a base on this tooth? Hands up. Any more? Who would put a liner or a base? And usually the liner and base is going to be either Dycal or GIC, correct? Yeah? Okay, a few nods, very good. Now, the first question I ask for these sort of questions is, do we add a liner or a base? I don't like this question because that's not the correct way to ask. The question that you're actually asking is, do you do indirect pulp capping, because that's essentially what you're doing with a liner. Is that right? Yeah? Well, we used to think, especially during the times when we're doing amalgam, that the point for indirect pulp capping is A, to seal the deep dentin, and also number 2, to encourage the formation of tertiary dentin. Correct? So we know that this is true for amalgam. Now the question is that, how about for composite? Does this still apply? Let's look at the research. Before we start, let's figure out first, who here still uses di-cal for the fillings? Hands up. A few nods here and there. How does di-cal work? Di-cal is a very alkaline solution, and what it does actually is that when you apply di-cal on the surface of the tooth, because of it being really alkaline, it's basically irritating the nerve. It's irritating the nerve so much foam that it's causing an inflammatory response that forces cell differentiation, that is forcing the nerve to create a new layer to protect itself. That's the tertiary dentin, right? So, in a way, this is the reason why when you put di-cal, patients hate you. Patients say it's very sensitive, right? But that's fine and that's necessary even when you're doing amalgam fillings. Because for amalgam, there is no seal. You have to rely on di-cal to create that protection. So what does the paper actually say? So they did a research where they kind of compare doing a deep filling with di-cal versus doing a deep filling with resin directly. So no line and no base. Okay, what did they find? Well, they find that the outcome of indirect pulp treatment was actually similar. Alright, regardless of whether you're using di-cal or whether you're placing a bonding agent directly. It's similar. Not bad, it's similar. How about GIC? Now, all of you should be familiar with the closed sandwich technique, correct? That is when we do your cavity preparation, the first layer is going to be GIC, and then you put a filling on top. All of you have heard of that before, correct? Good. Most of you are doing this as well. Doesn't matter. So they did an 18-year study where they compared fillings where you have GIC as a base and without GIC as a base. What do you think is the result? Have a look. Acceptable failure rate of 2% are achieved on both techniques. What does it mean? Both are the same. There is no improvement of survival rate. So meaning to say, if right now you're doing di-cal, you're putting GIC, you don't have to stop if you don't want to. You're not doing anything wrong. My point is, it may be unnecessary because the difference is negligible, right? For the younger generation, we know what this is. This is scoping review. We know when it comes to research and literature reviews, this is the highest level that you can get. What did they say? Now this is really interesting. Listen, there's inconsistent evidence regarding the difference between a resin-based composite when placed with and without a liner. There's very little evidence to say that it makes a difference. It says that there's no evidence between the failure rates for these two methods. So what they're trying to say is that placing these liners is an unnecessary step. It's an unnecessary cost that you could save and pass to your own patients, to the public. So my point to you guys is that if you are using a base, a liner, that's fine. Consider skipping that step from now on. Now, how about direct? How about direct pulp capping? Direct pulp capping basically means that when you have a pulp exposure, something that looks like this, right? Do you put liner in base? Yes, of course you do something about it. But provided that you are sure that the tooth is alive, the tooth is vital, the tooth is not bleeding, that it is a mechanical exposure, so on and so forth. This is all the guidelines that's provided by the American Association of Endodontics that came out in 2013. But the material choice that you should be using used to be calcium hydroxide, GIC. The advice right now is, if possible, when possible, we're looking at bioceramics because there's a better success rate. You understand? So, that's the first thing to consider is whether you want to put a line or not. The second question that we want to ask is that, do I remove all decay? Now, this is something I'm not sure in Vietnam and Hanoi, what are they taught in dental school? When you have a cavity like this, do you remove all decay? Are you taught both complete caries removal or are you taught selective caries removal? Can you give me a rough idea? Are you taught selective caries removal in dental school? Yes or no? Yes. I see nods. That's good. Now, selective caries removal in a lot of countries is still controversial. Some dentists still say that it is absolute rubbish. What does the research say? Hilton did this research, and what he's saying is that infected dentin must be removed completely around the EDJ, around the enamel dental junction. This one, I think most people know this. However, selective caries removal can be performed at the deeper part, meaning to say you can purposely leave decay on the deeper part near the pulp. And the purpose of that is you want to minimize any disturbance, damage on the pulp itself, minimizing the discomfort patient will get, minimizing the risk of root canal treatment. This is pretty much one of the reasons why we use selective caries removal. Now, so what he's saying is that it's not necessary, it's not required to remove all caries to have good success. This is the key point. Provided that the restoration can seal the lesion from the oral environment effectively. This is the key thing. The key thing is that if you want to do selective caries removal, that's fine, but it has to be sealed. This is why we talk about rubber dam. This is why we talk about cavity preparation, right? So, the point that I'm trying to make is that you have to make sure that everything is sealed, is cleaned up around the EDJ. And the only way for you to know this is through magnification. You cannot see what you cannot treat. Can you do me a favor? Hands up. Who here is using loops? 1, 2, 3. Be proud. Okay. For those who are not using loops, buy loops. They are very cheap now. TP them, if you're not selling loops, sell loops. Okay? Very, very affordable nowadays. They're very, very cheap nowadays. It would improve your quality of dentistry that you're providing massively. Right? Look, here's the key things when it comes to pulp capping. This is what they say. There are a number of studies that evaluated the fate of the cavity lesion, meaning to say, after you purposely remove and leave decay, what actually happens after a few years, right? And what they found was that, well, partial caries removal had equal success. We talked about that. What they also found is that the caries lesion decay that used to be soft, used to be light brown, is now hard, dry, dark brown. They looked at the bacteria that's inside those lesions, it basically dropped to almost zero. So we know that's effective. So what is he trying to say? Please take note of this. This is why I'm spending a lot of time on this. The type of liner is less important to the success than the placement of a well-sealed restoration. Which brings home to my point is that it doesn't really matter what you use. It's how you place the material. Does that make sense? Yes? Okay. So, effectively, whether or not you do total caries removal or selective caries removal basically depends on the vitality of the tooth. What am I trying to say over here? I'm going to skip through this really, really quickly, but here's the point. If you're dealing with a tooth that is, vital, is far away from the pulp, there's a decent amount of healthy dentin that's left in there, especially when you're dealing with an anterior tooth where you don't want any discoloration, by all means do total caries removal. You can afford to do so, the risk is very, very low. However, if you're dealing with a case where we know that, say for example, the patient is presenting with reversible pulpitis, for example. Reversible pulpitis, if there is enough dentin, yes, by all means, total caries removal, depending on the x-ray, right? However, if say for example, the patient starting to have some form of lingering pain, the patient starting to present signs that is suggesting that the reversible pulpitis is on its way out, then these are the situations where selective caries removal is necessary. You still need to warn the patient that root canal may be needed, but you're trying to be the good guy by trying to avoid them the time, the effort, and the cost of a root canal treatment, right? This all has to be communicated really, really well with the patient. You tell patients, I'm purposely leaving the cake, not because I'm a bad dentist, but because I'm trying to save your tooth, right? So we go on and on and on with different examples. But essentially it's this. The only time you do total caries removal is when the tooth is perfectly fine or the tooth is perfectly dead. If you're doing root canal treatment, if the tooth already has irreversible pulpitis or pulpal necrosis, there's no reason for you to do selective caries removal. Remove everything. Yeah? So cases like this, and this, and this, and this. No reason to redecay. Pulpal necrosis, same thing. The root canal specialist in the room, is this good enough? Approve? Approve. So, it basically just depends heavily on the vitality of the tooth. Are we okay so far? Do you have any questions that you want to ask? Okay? No? Then let's carry on. Let's talk about etching one. The concept of etching is not new. We've been doing it since 1955. It is started by this gentleman over here. Granted, back then, when he was doing etching, when he was proposing the concept of etching, it was quite controversial. Back then, the concentration of etch that he was proposing back then was around 70-something%, as opposed to the common 35%. However, the principle and the advantage of etching enamel really hasn't changed, and until today, no matter what bonding system you're using, etching to enamel still has to be done. Even if the product says it's self-etching and you can choose not to etch enamel, still always etch enamel, because it gives you that level of predictability. Etching enamel is probably the most predictable thing that you can do in dentistry itself. But what about dentin? How do we etch and bond dentin? Who here uses 3M Scotch Bond? Hands up. What other bonding agents are you guys using? Okay, look, here's the thing. When we etch and bond dentin, it depends on the type of bonding agent that you're using, but it follows a couple of rules, okay? The number one rule that you want to take note when you etch dentin is you do not over-dry the dentin, because when you etch dentin, what you're doing is you're exposing all the collagen fibers. Alright? When you dry the dentin, and inevitably you over-dry it, what happens is that the collagen dentin collapses. And when it collapses, it forms like an air pocket. And that air pocket is what causes post-operative sensitivity. Okay? So one of the biggest problems that people do, one of the mistakes that people do is they over-dry the dentin before they put the bonding agent. Now, in the past, when we were still using third generation, fourth generation bonding agent, when it is a separate bottle, the primer and the adhesive, that's less of a problem because after you, even if you over-dry the dentin, and you use a product like Optibond FL like Kerr, when you put the primer gets the collagen fiber to stand up again. So therefore, in the olden days, when you're using the old material, it is more steps to do. It's harder to do well. The patient gets less post-op sensitivity because you're separating the steps. You're allowing the fibers to stand up again. However, with the newer materials nowadays, the universal system, the one bottle system, one thing that you also have to remember is that you have to take your time. You have to be patient. What do I mean by that? When you apply a bonding agent, the mistake a lot of people make is they don't put enough, they just put a little bit on the tooth, and then the nurse, and then you immediately like cure. That's a problem, because one thing you have to remember is that the dentin that you're working with is like a sponge. You have to allow time for the bonding agent to soak into the dentin. And depending on the material, the brand of material that you're using, it can have different, very, very different effects. Those who use 3M Scotch Bond, one thing that a lot of people don't realize is that after you apply the bonding agent, if you wait for 10 seconds to allow the composite, to allow the bonding agent to soak in, you increase the bond strength by almost 20 to 30%. Right? So what I'm trying to say is that there are some bonding agents that will require you to take time, will require you to be generous, will require you to wait. For some bonding agents, it doesn't make that much of a difference. So far so good? Yes? Now, I get asked this a lot. I get asked like, what can I do to learn about bonding? How to do good bonding agent? What books, what textbooks to learn and things like that. I always tell them that the best book to learn how to do your bonding properly is called the instruction manual inside the box of bonding agent that you buy. Because a lot of times people don't realize different bonding agents have different protocols. Some protocol will require to lightly air dry for 20 seconds at a certain distance. Some bonding protocol tells you don't air dry. Some bonding protocol says you have to make sure the tooth is a little bit wet, so on and so forth. So the way I choose a bonding agent is that I want the instructions to be clear and simple. Does that make sense? Right? Now, one final thing that people can look into is selective etching, or the question of do we still etch dentin nowadays? Again, depending on what you were taught in dental school, this is essentially what's happening. Look. There is an enzyme inside your teeth that gets released over time. And what happens is that this enzyme called MMP, what it does, it over time breaks down the bond that's formed between the tooth and the resin. Okay? This is natural. Everyone will have this. The problem is that there are certain things that you can do to increase the release of this enzyme. Namely, is two things: acid and moisture. So one of the reasons why nowadays we do not etch dentin anymore is we want to limit the release of this enzyme. The second thing to remember is that inside your bonding agent, there are some monomers like HEMA, H-E-M-A. Over time, it sucks in water. So when it sucks in water, it releases more enzymes. So what you're trying to look for when you're looking for a bonding agent is you want a bonding agent that doesn't doesn't absorb as much water. So basically you're looking for one that is hema-free. Do you understand? Okay? But here's the problem when people argue, no, you still need to etch dentin. Why? Because if you don't etch the dentin, there will be a smear layer on the surface that will affect bond strength. Yeah? That's why one of the protocols that I use, that's introduced by a lot of European dentists right now, is after you etch your enamel, you use what we call a microabrasion unit, or basically micro-etching. Sandblasting, basically. Sandblasting machines, again, they're very cheap. If TP Dent don't sell them, you can buy them on AliExpress. The problem if you buy this one over here, that's very cheap and affordable, is that the powder, the aluminum oxide powder, goes everywhere. It's very messy. That's why sometimes it's not a bad idea to invest in the better ones. Okay? This is the one that I'm using at the moment. It costs a bit more, but ever since I started incorporating them in my workflow, my failure rate basically dropped all the way to 0. Because now I have best of both worlds. I'm not releasing the enzyme, I'm cleaning away the smear layer, I'm increasing bond strength tremendously over a longer period of time. So in conclusion, when it comes to bonding agent, these are the things that we're looking for. Now, the product that I've been using for a very long time, almost 9 years, 8 to 9 years right now since launch, is a product called GC Genial Bond. Okay? GC Genial Bond has basically fulfilled everything that I've mentioned a while ago. It's universal, it's selective etching, it contains the monomers that allows you not only to bond to teeth, but also to porcelain, to zirconia, to metal, so on and so forth. It's hema-free. This is key because you don't have a monomer that sucks in water. Understand? But the key point, I'm going to show you this again, is this. Remember how I said for 3M Scotch bond, you have to wait for that 10 seconds to increase the bond strength? Remember that? For this material, the lovely thing is because it's so wettable, it soaks into the dentin really quickly, that you don't really have to wait for 10 seconds to achieve that high bond strength. This is great if, say for example, you still choose not to work with a rubber dam and you have to work fast. This is great if you're dealing with a difficult patient. This is great if you're dealing with children, because you have less waiting time. Okay? One more factor that I look at, is basically the thickness. For GCG Premium Bond, thickness is around 3 to 4 microns. Scotch Bond, 6 to 10 microns. For the older materials, SC Bond, OxyBond, FL, we're looking at 20 to 30 microns. So when you do your fillings, and you see gray thin line, that's that. I don't want to see that. No one wants to see that. So I want something that is reliable and thin, but only strong, if not stronger. Okay? So, when it comes to the choice of bonding agent, does that make sense now? Now, I have cleaned the surface, I have prepared the surface, I've added my etch, I've added my bonding agent. I'm prepared now finally to do my first layer to seal up the exposed dentin, right? Now, I'm guessing nowadays most people are familiar with flowable composite. And for most people, what they do for the first layer, they're adding a flowable composite. Why? Because the surface of the composite sometimes is very rough, there are a lot of sharp corners, so you want to make sure you seal it up with something that's flowable to minimize the amount of air void. I'm sure most of you are already doing it. Yeah? But one of the things that we kind of remind people is that when you're doing that, you're basically healing the tooth, you're sealing up the tooth. I want you guys to think, to change your mindset when it comes to etch and bond. Etching and bonding is not about adding a layer of glue or cement to make sure that your fillings fits or stays there. Doing the dentin seal, if you treat dentin, exposed dentin like an open wound, doing a dentin seal is sealing that wound. That's why in my practice, whenever I do a filling, 70% of my time is on that first layer. Because I want to make sure I do that well. Yes, I spend more time, probably I spend more cost, but I want to make sure that layer is done well so that my fillings don't drop and patients don't complain of sensitivity. Right? You notice I don't really care so much about the occlusal anatomy or aesthetics. Patients don't care. Right? We should care a little bit, but patient cares more about does it hurt afterwards or is it going to last long? And doing that first layer really, really well allows me to ensure to give that confidence to my patients. Right? So, my take home for you guys is this, okay? Is that the moment you start treating exposed dentin like a delicate open wound, you understand that sealing, that the dentin bonding and sealing is really like closing a wound. Yeah? If you seal it, it will heal. As simple as that. The thing that you have to remember is this. Especially for the first layer, you take your time. I'm going to share something. How many of you right now are in private practice? Okay, a lot of you are in private practice. Do you know what is the biggest waste of money in private practice? The biggest waste of money in private practice. You know what it is? Free redos. Let me say that again. The biggest waste of time and your money is to do treatment for patients for free because it didn't work the first time. You lose time, you lose cost, you lose patient trust. It's the biggest waste. However, the time investment that you are putting in to do that first layer well will cost you a little bit more initially, but in the long run, you avoid this kind of time waste, this financial waste, and the loss of patient trust. So my advice to all of you, especially when you're in private practice, is this: take your time, especially for the first layer. Alright? So this is where we choose a flowable composite material. Now, flowable materials used to have a very bad reputation. 10, 15 years ago, they are known to be weak. How did we used to make flowable composites? How do we used to make composites flowable in the past? We make composites flowable by reducing the amount of fillers that's inside the composite. Correct? We reduce the fillers, we make it a lot more flowy. So it's great for adaptation. The problem with a composite with low filler is that massive amount of shrinkage and really poor strength. That's why 10, 15 years ago, flowable composites had a very, very bad reputation. Now things have changed nowadays, okay? Because the flowable composite nowadays that we're doing is almost as strong, if not stronger, than the conventional paste composite that we are. Why? Because we managed to make it flowable not by making the fillers less, we make the fillers smaller, way smaller. What we also do is we cyanate each and every individual flowable, each and individual filler that we have to ensure that the filler and the resin is well incorporated and well bonded. Okay? So, the type of flowable that I use now for the first layer, I want something that is flowy, that is runny, and that is strong. And the material that we're using right now is what we call Solare Flow. Solare Flow. This is not a new product. This has been launched in Asia since 2008, 2017, if I'm not mistaken. But it actually launched in Australia and many countries, many parts of the world in 2015, I think, somewhere there. But it's in a different brand name. Now the lovely thing about it being in this part of the world is that they would send the product, they would start using the product in other countries. If it's good, they bring it here, repackage it, make it cheaper for us. So we know the product that we're using now has been tried and tested. This is one of them, okay? And I love it. And the lovely thing is it's affordable. It's very, very, very affordable. Now, when we talk about strength, 165 megapascals, this one is one of the strongest ones that there is. In terms of flowability, here's the thing. I want my flowable composites to flow. I do not want them to flow out of the mouth. So having something that's flowable but not too flowy is important. So what we have over here, if you look at flow X, that's solare flow. Okay? If you look at flow X, that's solare flow. Now, the second thing that I look at, and this is really important to me, is this, is radial opacity. Let me ask a question. How many of you would take an X-ray of your own fillings immediately after you place it in a patient? Most people don't. But you would happily take an X-ray of a filling that's done by another dentist and judge them. Yes. Here's the problem, okay? When we put a flowable material as the first layer of liner, it's really important for you to know when you take an X-ray, am I looking at my liner, my first layer of flowable composite, or am I looking at decay? And the problem with a lot of the older flowable materials is that it's not radial opaque, it's radiolucent. It looks like decay, and that's a problem, okay? Nowadays, if you look at the newer products that's developed by GC, the Solare Flow and the Genial Universal Injectable, yeah? They are all very radiolucent. How radiolucent? This radiolucent. It looks like amalgam inside the mouth. Compared to the competitor product, yeah, you are looking for something that really stands out and shines in X-ray. This to me is important for diagnostics. It's important for me for review. If you look at this case over here, which we did, this is before, that filling is not amalgam. That filling is Solare Flow and Solare Sculpt. You want that. You want to know exactly where your filling is and how tightly adapting it is to the dentin. You want to be able to be sure that what you see has secondary decay or not. Does that make sense? Yes? And finally, of course, you want to make sure that whatever material you use is adaptable, it is versatile. Now, there's a lot of studies out there that explains the benefits of flowable composite. I'm going to skip that right now. You can take a photo of this if you want. Very, very good paper that kind of summarizes everything. But here's the thing. How do you choose the material? How do you choose a product? Yeah? If I'm a dental company and I come up to you and I say, Doctor, I have this new composite over here. I want you to buy it. What is the first question you're going to ask? How much? And have discount or not? Of course. Do you know when I was a new dentist, because I want to pretend to be smart, do you know what I asked? Show me the research paper. Tell me what's the filler content. Show me the shrinkage percentage. I want to pretend to sound smart, right? Here's the truth. Every company that launches any composite will say that their composite is the strongest, is the best, it will not shrink, it will everything. So asking these sort of questions are useless, in my honest opinion. It all comes down to the reputation of the company, right? But that's beside the point. In my honest opinion, the most important thing when you choose a material is you have to see whether this material is comfortable in your hands. So you know that you can comfortably and predictably move that material from the syringe into the patient's mouth. And this is very personal. Everyone is a bit different. Some people like the composites firmer, some people like the composites softer. Let me give you an example. Those who are using 3M composites, you like your materials firm, right? They tend to be the older generation. You know why? Because it reminds them of amalgam. There are some dentists who prefer the softer type of materials. Tokoyama is one of them. Shofu is one of them. They're very soft, they're very sticky. Some people love them, some people hate them. Okay? So that's why I say, if you ask me, does GC make the best composites? My answer is, I don't know. Because it really depends whether or not this is a product that works well in your hands. Right? For me, for posterior restorations, I want a material that's a little bit stiff. It's not sticky to my instruments. It's something that I can sculpt and adapt quite easily without moving around. Okay? That's what I'm looking for. So, to answer your question a while ago, when you have a rep that comes up to you and say, Doctor, I have a new material over here, the question that you really should be asking before you ask for how much is, can I have a sample to play with, please? Alright? The second thing that you should do when you have that sample, after you played with it, you tried it, oh, I like how it feels and all that, is what I do is I take an x-ray of the material. I want to see how radio opaque it is. Like I mentioned, it's important for me to know whether, if I take an x-ray, that's where my filling is and it's not secondary decay. So these are the two main things I look at, the handleability and radio opacity. Then the third thing I look at is translucency. What do I mean by that? When we talk about translucency, it means that when I put a filling over there, am I going to get color, decent color matching, or is the filling going to look gray? I'll show you a case later on. So, for GC, we have obviously different type of handling consistency based on the preference of the dentist, but also based on the area they're working on. But this is not the product I'm going to focus on today. The product I'm going to focus on today is this one, the Solare Skull. This is not Solare, this is not Solare X, this is Solare Skull. Although it's called Solare, it's a completely different composite. Completely different chemistry, completely different property. Okay? Sculpt has been around in Asia, at least launched in Asia in 2017, and I had the opportunity to start using them from the very, very early times. And until today, in 2015, it's still my main and if not only composite that I use for posterior restorations. It's a simple system. It comes in 4 shades, A1, A2, A3, A3.5. So this is meant to be a single shade solution. Handling is fantastic. Remember, when you want to test handling, don't just test it outside of the mouth because it's cold. You test it inside of the mouth, or you test it in a warm area because you want to see at 37 degrees human temperature, does it slump? This is the problem that I get with Tokoyama, is that it's great outside of the mouth. The moment it's inside of the mouth, it keeps on moving. It's very hard for me to control. Okay? Now, what about strength? What about radio opacity? Radio opacity is off the charts. It's fantastic. It's comparable. It's comparable to the 3N material, but if you compare it to like the older products like Solare, you can see that it's a massive difference when it comes to radio opacity. You want something that is more radio opaque than enamel. This is key. This is important. Right? What about strength? claim that this is the strongest material in the world. I don't care. I need it to be stronger than teeth, that's it. Okay? So that's fine. This is the case that I started doing in 2018, sorry. This is a very good example on cases where it's impossible for me to do without rubber dam. Okay? After restoration, after rubber dam is removed, this is 2018. This is 2021. You can see that it's still there. The margin integration is still good. It's a little bit worn down, but then again, this is a back tooth. I assume and expected some wear and tear. But look at the gums, how the gums just heals over the composite. This is 2023. This is 2024. So this is a patient, this is one of the earlier patients that I've used it and I still track him until today. Alright, I'm seeing him in 2 months' time again, so the next lecture I do is 2025. This is Nicole. Nicole came in with this tooth. The tooth is alive. Alright? Because now you understand whether or not I carry removal depends on the vitality of the tooth. So it's very important that you do a vitality test before you do any treatment. The tooth is still alive here. Alright? So we decided to just do something, just to do direct composites. Okay? I'm using the polydentia band called Unica to help me build this tooth up. This is what it looks like after the restoration is done using Solaris Sculpt, single shade. This is what it looks like in 2018. And I want you to have a look at this. This is 2023. Not only that it's still there, not only is the shade still stable, look at the gums. Look how the gums just adapt really, really nicely around that large restoration. I'm quite happy with that. Remember this case that I showed you a while ago? This is before, this is after, without putting a liner, no dical, no GIC. All I use is Solaris Flow and Solaris Sculpt. Okay? This is what it looks like. Why did I say translucency is important? Who here have used Densifly Ceramics? Densifly Ceramics is the first material, it's the first composite I used as a practicing dentist when I came out of dental school. And I will tell you even today, when it comes to handling Densifly Ceramics composite, number one, cannot fight it. The problem with that material is very translucent. Meaning to say, if I use that material in this case, the dark shadow underneath is going to shine through. Your filling is going to look gray before you even wait for it to fill. Okay? So you want something that is color-wise relatively opaque, color-wise can blend really, really well to the surrounding areas. So you don't need to use Omichroma from Tokuyama. This is great because the color scattering is fantastic. This is Darren. Darren is 74 years old. He's a retired math professor, and he doesn't have high aesthetic demands. He came to me and he has one request. He said, "Doctor, I want to be able to smile without my granddaughter feeling scared." That was his request. So for cases like this, where you know you don't have that high of an aesthetic demand, Solaris Flow and Solaris Sculpt single shade solution would be great. What did we do? This is what he looked like. That's dead, but very firm. So we decided to hold on to it first. Okay? This is isolation. This is caries removal. We build up the proximals. This is all using Solaris Sculpt. This is Solaris Flow and Sculpt A3.5. Okay? Good. talk about glycerin, why this is important later on. And this is what it looks like immediately after treatment. Look how well it blends, even though it is a single shade. Same patient, looking at the back teeth. This is pre-op. This is after caries removal, selective caries removal. And this is solari flow and solari skull. I added some tints over here just to show off. You don't need tints. You don't need stains. This is just for fun. Okay? Class 5, same thing. This is solari flow, solari skull. Okay? For this case I think I used injectable, but just to let you know that tooth is dead. So that one we need a root canal treatment. Oh no, this one I still use solari flow. Okay. This one I use injectable. So this is what it looks like now. Using a single shade system. Alright? This is what he looks like now. That's still there. Okay? So this is solari skull. So far, does it make sense? So far, any questions? Still good? Alright, fantastic. I want to talk about genial injectable. Injectable is a product that launched a couple of years right now, and it goes hand in hand with solari flow. They're both flowable materials, but for solari flow, it is a very flowy material that's very good for the first layer, for sealing. But if I want a material that's good for build-up, I don't want the material to flow out. I want it to be stackable. Alright? So this is where genial universal injection, or what we call GUI, G-U-I, is very, very good at. Now, for those of you who have been on social media and looked at some dentists, especially in Europe and America, posting cases, they would have heard of this material, and one of the things that they would know is that they would use this for a technique called injection molding technique. Okay? Injection molding technique is a method to help quickly build up anterior teeth. I'm not going to talk about that just yet. But I'm going to show you how I use injectables for my posterior cases. Because here's the thing that a lot of people don't realize. Genial universal injectable, GUI, is fantastic for core buildups. I love it. Why? This is a case. We dealt with the 1-4 first. We restored it with solari flow and scalp, just like how we said a while ago. We removed the old material, we removed the old restoration, we did the necessary caries removal, we sandblast, conditioned the surface, and I love using this. It's Genial Universal Injectable GUI XBW, shade XBW. Why do I use GUI? I use GUI for my core buildup because it's tough, it's hard. So not only for the fact that it lasts long, when you start prepping your teeth for crowns, the material preps like teeth. What do I mean by that? Traditionally, if you use the older composites or the normal composites, when you're trying to prep a tooth, the moment you reach the composite, what happens? Zzz. Yeah? When you prep with this, it feels like tooth. So your prep is always going to be really, really, really clean. I love it. That's number one. Number two, why do I use XPW? For two reasons. Number one is that I can use it to very, very effectively mask any discoloration underneath, especially around the cervical area. And number two, it's very clear for me to know which part is built up, which part is tooth. It's very good for assessment and diagnosis. Okay? So for me, I'm probably the biggest user of XPW in Singapore right now. Okay? And I encourage you guys to start using this. The prepping is fantastic, especially if you do a lot of root canals, endos, large restoration. This is really, really good. Okay, so this is, we continue to work on the 7. So this case is simply cemented with Fujisen. Okay? Another case, Henry came in. Henry had the 7 crown come off. I had a look at the tooth. The tooth is not savable, so I told him, Henry, I'm sorry, the tooth has to go. As I was extracting the 7, the crown of the 6 came out. And then Henry said, please, I don't want to lose that one as well. I'm like, okay. I temporarily put the crown back in. I took out the 7, and I asked him to come back. Why didn't I treat the 6 at the same day? Because I want to know, is the 6 still alive? So I have to do a vitality test first. The tooth is alive. The tooth is alive. I have no idea why, but the tooth is still alive. So we sealed up again, XPW. Put an implant on the 7. This is Osten. This is what it looks like afterwards. Okay? So you can see like my workflow is pretty much the same over and over and over again when it comes to my indirect restorations. Always use XPW, and always use SolariFlow as a first layer. I use XPW to build up my core, and I basically start prepping. And the results I get, because my preps are always going to be much better than if I were to use other composite build-up materials, my lab loves it. I get better results, I get better predictability when it comes to fit. One last case just to show you. This tooth is dead. We did root canal treatment for this tooth. We build up using using genial gooey XPW again, mainly because this is a high, I know this is a molar, but this is a very, very high aesthetically demand patient, right? I want to make sure that whatever it is I'm doing, I'm not going to allow the discoloration that's underneath the tooth to affect the final result. So that's what she looks like after fitting. Are we okay so far? All good? Thank you. I want to briefly talk about light curing because this is actually quite an important topic. What light cures do you guys use? Ivoclar, the blue phase, woodpecker. Look, with regards to light cure, there are a lot of brands out there. This is what I personally use. I use the one that's by Velo, one of the strongest, one of the best light cures out there. And here's a problem for their company, is that this light cure is so durable that I can use it and pass it over to my grandchild and he can still use it. And this is bad for their business. But it's so durable that my nurse has dropped this so many times. It's still working. But here's the key thing when it comes to choosing a light cure. You have to make sure you're choosing a light cure that is small at the head. If you look at Blue Phase by Ivoclar, you notice that the head is like this, right? Like this, it bends down. That's bad because it means that the patient has to open super wide for you to actually use it. We're Asians, we have small mouth, doesn't work. So woodpecker, okay, the light intensity is not as strong, but understandably, it's way cheaper than that. However, that cost more would last you 3,000 lifetimes. Okay? So something to consider. That's with regards to light curing. Is that okay? Now, let's move on to matrix pens. here is using a sectional matrix already? Hands up. For the composites. A few hands. Who here is still using the Toffel-Mayer? Hands up. You're using both. Okay. Look. There's a reason why when we're doing amalgam, we can easily use a Toffel-Mayer band. Because when we use a one of the difference between a Toffel-Mayer band and a sectional matrix is that the sectional matrix is already pre-curved. Yeah? So with a sectional matrix, you can recreate that convex surface on the interproximal wall very easily. For amalgam, you can still use a Toffel-Mayer band, because the thing with amalgam is that when you pack the amalgam into the hole, the packing force will deform your Toffel-Mayer band already. Remember, for composites, we don't pack composites. We layer composites. So it's impossible for us to do composites with a Toffel-Mayer band and expect it to have the natural tooth contour. Alright? That's the reason why when we take an X-ray like that, it's very, very clear which tooth is it that we use a sectional matrix, which tooth is it that we use a Toffel-Mayer band. Now, here's the thing to take note, alright? Especially for the younger dentist who's starting to use sectional matrix, those in private practices. When you use a Toffel-Mayer band, the problem is that you get a tooth where you build up a tooth where the contact points are very coronal. It's very high. Now that's a problem because it means that you've created a very, very large space for food to get trapped. Alright? And that's when patients complain food gets trapped very easily, I don't like it. The second problem with a Toffel-Mayer band is that sometimes if you don't adapt it properly, it's really easy for you to create a space around there, and therefore when you do a build-up, you get that overhang, you get that ledge. Very easy for this to happen. So this is the reason why nowadays, whenever we do posterior composites, it's pretty much gold standard right now, for me at the very least, is to be able to use a sectional matrix. Now, there are many brands of sectional matrices out there. Who here uses Garrison? Garrison's sectional matrix are very expensive. I don't like it. Garrison, V3, V4, Palodent by Dentsply, all of them are very, very, very well designed, but very expensive and very soft. Meaning to say, if I put it in the mouth and it bends and it crumbles, that's it. Throw away. It's very expensive, wasting money. So the two brands that I use nowadays, one is called Polydentia, which I'm going to show you later on. Another one is a Russian brand called TORVM, T-O-R-V-M. Okay? They're very affordable, they're very good, they're very durable. Okay? And it's pretty much what I use in my own practice nowadays. Now, when you use a sectional matrix, the lovely thing is that you're able to create a wider contact area. But the key thing to take note is that you have to make sure the sectional matrix that you choose has to be the correct height. What do we mean by correct height? You have to make sure that the sectional matrix you choose is roughly the same height as the tooth next door. Now this is really important because what happens, because I'm sure a lot of you, when you go in your clinic, you have one sectional matrix size. You probably just have one. And a lot of times they're too big. Now when they're too big, the problem is that you'll have a tendency to overbuild the wall. When you overbuild the wall, you will tend to overbuild the occlusal surface. When you overbuild the occlusal surface, that's when you spend 10, 15, 20, 30 minutes doing the adjustment and making the occlusion really flat. Do you understand? So, it's really important to make sure that you get the right height, the right size. Now, a lot of companies, when they sell these sort of sectional matrices, they have the premolar size and the molar size. Ignore that. ignore that. For me, I have small and big. Small, medium, and big. 70%, 80% of the time, when I treat Asian patients, I use the small one, regardless whether it's premolar or molar, because we have smaller teeth. Okay? So some people would say, oh, actually, I know what I can do. I can, if I have a long sexual matrix, I just push it down, push it deeper, push it into the gums more. And then the problem when you do that is that you end up with that. That's when you create ledges. That's when you create overhangs. Okay? So this is why it's important when you choose a sectional matrix system, you have to choose something that gives you 2, maybe 3 sizes. One more thing. How about the wedge? I go cheap. Garrison wedges are horrendously expensive. I don't like that. I go for wooden wedges. The reason why I go for wooden wedges is because the selection of wedges can influence and cause issues of open interproximal contacts. Okay? Because if you choose a wedge that's too big, that pushes the sectional matrix out. That's the thing that's going to give patients more food trapping. The reason why I go for a wooden wedge is purely because it's significantly easy for me to trim and adjust chair side if I feel that it's too big. Alright? So the choice of your wooden wedge is still really, really, really important. Now, of course, if you have a sectional matrix, that's good. If you do not have a sectional matrix, there's a really, really quick tip that people can do to force a more convex surface. So you add a little dimple over there, and that's basically where you tell where you create the contact point at a certain position. I don't do that anymore because right now I don't use Stoffel-Meyer bands at all. I maybe use it for children, that's really about it. Okay? So, using the same concept that we taught you a while ago, the building of the wall has to be done well to create a very, very nice seal. When you can do that properly, patients don't complain about food trapping. Patients don't complain about open contacts or food getting stuck. They can't floss, right? Of course, in some cases, you cannot use a sectional matrix. This is where you have to go back to the Stoffel-Meyer band, which is again sealed using things like Teflon tape to make sure you can have a really, really nice seal of that. This is a very old case. This is a very, very old case that we've done around 10 years ago. This was, I think, back in the days when I was still using Octobond FL bonding agent, I think. But if you do these sort of methods, you can create really, really, really nice contours where patients don't get food trapping. Now, we're still using Octobond FL method. Okay? So far, so good, right? Now, what have we done so far? We have isolated, we have done the cavity to preparation, we have etched, we have bond, we have added the first layer, we have built up the wall already. Now we have a +1. Finally, we have a +1. Okay? At this stage, I always tell a joke that once everything is sealed up, I don't care what you put inside the hole. It will work. Okay? I don't care what you put inside a hole or how you put it inside. Alright? When we talk about build up, some people say, you have to build it up in layers. Some people say, you have to build it up in segments like this. Also, this is where people start talking about bulk fill materials. At this stage, I don't care anymore because even if there is voids, even if there is shrinkage, right? The effect that it would have on my final restoration is absolutely minimal. Okay? So that's why someone came up with the concept of the super close sandwich technique, where we do everything like we said a while ago. We edge, we bond, first layer using resin flow walls, we build up the wall, and then what they do is this: they fill up the cavity using GIC. Doctors, what is the one thing that GIC can do that composites cannot?
Do not say fluoride release. The reason why I say do not say fluoride release is because because GIC doesn't release fluoride. GIC is a fluoride reservoir. Hold on. Let's take a 5-10 minute break, okay? Yep.